Myself, I am Rohit Babu, Assistant Professor, Department of Burns and Plastic Surgery, AIIMS Bibinagar. Today I welcome Dr. Lakshmi Madam hardly requires any introduction, but just to the audience who hardly know her, she is Professor and HOD of Department of Plastic Surgery, Osmania Medical College. Ma'am has 25 years of vast experience in government service and 20 years in teaching plastic surgery, and ma'am has been EC member of APSI and NABI, and she's also been the former secretary and treasurer of APRASICON, State Plastic Surgery Association, and ma'am has been organizer and mentor for Plastic Fest program, which everybody knows, for the past 4 years, and she is the founder of Plastic Fest Challenge, which has been conducted successfully for the past 3 times. And to her credit, ma'am has received many awards, out of which few are Kilner Essay Award and Ethicon Ganga Fellowship Award in Advanced Training in Microsurgery and Hand Surgery in 2022, and Raja Sabhapati Leadership Award in 2023, and Mentor of the Year Award in 2024. And ma'am is been the MBE faculty and also various universities across India, and she conducted NABI midterm CME at Osmania Medical College, and which is a successful one, and she conducted various awareness programs to create awareness among the public regarding burns and plastic surgery, and she delivered various lectures at various conferences, national conferences and state conferences. We welcome you, ma'am.
Thank you, Rohit.
Ma'am, today's journal for our discussion was Standardization of Surgical Treatment of Acute Electrical Trauma. This journal was published in Brazilian Journal of Plastic Surgery, which was published in 2016. Authors were Edma Masi Lima Jr. and Victor Monteiro and Angel Parante and Gila Ferrari. And coming to the introduction of the journal, electrical burns are usually comprise 5 to 15% of the cases of total burn accidents, and the majority of the burn accidents are usually workplace accidents, in which high voltage burns usually predominate, and the victims being the most commonly male patients, and the mortality rates usually vary from 2% to 15% in different burn centers. For you, my question is, ma'am, is Osmania Hospital, being one of the tertiary care center and largest burns unit in both AP and Telangana, and the major workload is burns, and what is your day-to-day workload and statistics on these electrical burn injuries?
Yes. Rohit, ours is the second burn center started in India and the second biggest burn center in India. And the workload of electrical burns is 10 to 11%, whereas in Western countries it is less, it's 4%.
Yes.
It is because of the open electrical system we are having. And most of them, 99% are high voltage electrical burns.
Okay.
The victims are the young males who work in agriculture fields and on electrical poles and construction workers. So the incidence of mortality rate is not as high as you described, but if associated with cardiac irregularities, head injury or the spinal injury due to fall, and associated flash burns more than 50%, maybe the contribution for the mortality, whereas the morbidity is very high.
Okay.
Because the upper limbs are mainly involved as a contact organ. So the incidence rate for the amputation related to this is high. But execution of the protocol EDAF in our institute, the morbidity has come down and little functional recovery is good.
Okay, you mean to say, ma'am, this affects usually the actively working male patient,
yes,
young people.
Yes.
So you say this is a slow epidemic, though the mortality is not high,
morbidity is very high.
So it affects his daily living and all the stuff.
Yes, you can see in this slide the magnitude of the amputations in high voltage electrical.
Okay, you have a series of all the patients.
One time these many admissions were there getting treated for electrical burns in our institute.
Okay. They say an electrical shock on extremities has a very devastating effect, usually compromising the deep structures causing vascular thrombosis, which lead to progressive necrosis in the structures, which were usually look normal at the time of presentation. And there is a severe muscle injury, which is due to passing of current, which causes breakdown of the striated muscle, which releases the myoglobin, which is called as rhabdomyolysis, which leads to ultimate acute kidney injury. What is your opinion regarding this, ma'am?
Yes, that is true, because the tissue damage in electrical burns is because of the two theories:
Okay, ma'am.
thermal injury and electroporation, electroconfrontational changes at the cellular level. So thermal injury is high near the structure which offers the maximum resistance. So that is bone.
Okay.
So what we see is the tip of the iceberg. So the tissue damage is in and around the bone. That is most involved is the muscle layer.
Okay.
And the electroporation, electroconfrontation changes taking place at the nerve and the vessel muscles, leading to the thrombosis of the vessels, which leads to progressive necrosis. That is because of the vessel thrombosis.
Vessel thrombosis.
It will be seen at the end of 1 week or 10 days. So
Rather
up
than
to that time.
Okay.
And it is more extensive in the art parts also.
Okay. Coming to the main objective of the study, ma'am, it is the standardization of surgical steps in acute phase of debridement. And coming to the inclusion and exclusion criteria, author has included patients with electrical shock with areas of third degree burns and muscle breakdown, and he included patients with burn surface area of 3 to 25% and age between 15 to 50 years old, so that he excluded children and elderly. And coming to exclusion criteria, burns less than third degree and without muscle damage were excluded. This is a quantitative and prospective study conducted at Brazil during the period of July 2013 to December 2015. What he has done is, on acute phase, he has performed all laboratory tests for every 48 to 72 hours, including assessment of CPK levels, and he has advocated the taking photographs at initial presentation, pre and post-op periods, and all patients received intravenous fluid replacement using Parkline formula to maintain diuresis at the level of 100 ml per hour and maintain CPK levels less than 1000 international units. Do you think total body surface area is a reliable parameter for calculation of fluid management in burns? And what is the fluid management protocol you follow at Osmania General Hospital?
TBSA is not a good parameter to calculate the fluid requirement
In electrical burns.
because what we see is the tip of iceberg. The extensive damage is inside.
Okay.
So if the patient presents with myoglobinuria at the time of presentation, we give the fluid challenge and rapid infusion of the RL, and till the urine becomes a light yellow color and volume is good, we keep rapid infusion.
Okay.
Or we calculate the TBSA if there is compartmental syndrome or skip lesions. The entire limb is considered as TBSA, though the patch is 1 centimeter, 2 centimeter, but we take it as a 9%. 9%.
You mean to say we won't only, we are going to calculate the entire limb, not only the superficial patches where it is visible burns.
Yes. So that, and 7 into TBSA, how we calculate, and the body weight.
Okay.
Not the Parkline, because the requirement of fluid is high.
Always more in electrical
And
burns.
we should flush the myoglobinuria
Okay.
to prevent the renal damage.
shutdown.
Once the urine color is less and the urine output is good, we'll maintain the fluid rate is titrated according to the 1 to 2 ml per
1 to
kg per hour.
Per hour. Okay. Nice. According to Otto, he says like high levels of CPK, that is like more than 2500 international units, indicates very serious muscle damage and require urgent surgical debridement or amputation. And so he advocated like for giving high volumes of intravenous hydration until the CPK levels are less than 400 before proceeding to surgery. What is your opinion on frequent measurement of CPK levels, ma'am?
It's a very good parameter and indicator to predict the muscle damage as well as titrate our surgical procedures based on that. We don't do regularly in our institute as it is not available. But we have conducted one ICMR project, how it levels increased in the electrical ones. It is a very good parameter to assess the muscle damage, CPK-MB.
CPK-MB.
Yes.
Which is more specific to
the muscle damage.
Muscle damage.
And when you do debridement or amputation, the levels will come down.
Oh,
so it's a very good
indicator.
Yes.
If the center has availability of this CPK-MB levels, is a good parameter to check the serial monitoring of CPK levels.
Yes.
To assess the muscle damage.
Yes, muscle damage as well as it's a good predictor for the mortality.
Mortality, yes. Okay. As you say, like CPK is a very good marker, but most of the centers in periphery centers, and even most of the tertiary hospitals also don't have this availability of CPK. Do you advise something else as a clinical parameter based on your experience, which is little bit not as good as CPK, but which can be assessed by a surgeon?
Yes, it's a very good question, Rohit. That is what we follow at our center, EDAF method.
Okay.
So early debridement of the tissues or amputation or disarticulation. So the burden of the dead tissue is relieved. Okay. And apart from that, the early fasciotomy also. We don't wait till the loss of pulse and all. So this we give the fasciotomy and cover with the collagen. So the tissue damage or the extension can be seen through the collagen.
So you
and it as well as protects the exposed tissue, prevents the infection.
So it prevents the desiccation of the tissues.
Desiccation infection.
So you can see the muscle rather than checking for CPK. You can directly visualize the muscle and the health of the muscle can be assessed directly by day-to-day dressing. Okay.
No need to dress. Once it is collagen is covered, you can elevate also.
Okay, ma'am. Nice. Ma'am, coming to the results of the study. Study included total 15 patients, ma'am, out of which 9 patients, that is like 60% of the patients underwent amputations, like 13 surgical amputations were done with an average of 0.86 amputation per patient, out of which patient number 4 who underwent 3 amputations like toe, leg and thigh. It is a progressive amputation, and 1 patient underwent 2 amputations. What is the scenario of amputations in your institute for electrical ones?
It is last year statistics when we have observed. It is 30% of people undergone the amputation.
Okay, ma'am.
So what our protocol is EDAF, that is early decompressive fasciotomy, early amputation and early disarticulation.
Okay, ma'am.
We don't wait for the demarcation of the gangrene.
Okay, ma'am.
So what we do in addition to the amputation of the limb, we give a vertical fasciotomy on the proximal part,
so
that the status of the muscles we can come across. So if the muscles are not viable, they are not contracting and all, we go for higher amputation at that time only.
Okay, ma'am.
So that decreases the burden. Okay, if the muscles are healthy looking, color and contractility, we'll wait and cover with the collagen or with the tag stitches of the stump.
Okay.
So always skeleton amputation and proximal fasciotomy.
Okay, ma'am. Proximal fasciotomy. What you say?
Yes.
You say early decompression usually saves more limbs.
Yes.
Rather than waiting for we get imminent signs of compartment syndrome and everything.
Distal amputation, skeleton amputation, but sometimes the progressive necrosis will.
Yes, ma'am. Okay.
But in skip lesions, we should know the status of the muscles to decide the level of amputation.
Okay, ma'am.
So sometimes what happens, there will be lesion here and lesion here. Instead of going for below elbow amputation, if muscles are not good, at that time only we go for the above elbow amputation.
Coming to my next question now. As the author said, all the patients who had progressive tissue destruction needed serial debridements at different times. With the interval, usually he kept between 48 to 72 hours, so that the patient will get stabilized. Do the patients require regular serial debridements, and what is the ideal interval you keep at your institute?
So we to keep the same interval, but we observe through the collagen. So the tissue showing the necrosis, we go ahead with the debridement and again cover with the collagen.
Okay.
And this we follow for 1 week to 10 days in electrical burn. But if arc burns are there, at least for 2 weeks.
2 weeks.
So we cover with the flap or the skin graft once the bed is ready in compartmental syndrome group. We classified our upper limbs to 3 categories.
Okay, ma'am.
So I'll show that classification. So accordingly we follow the treatment protocol also. So in compartmental syndrome we give decompressive fasciotomy on first day 1 or 2 and observe after covering with collagen, and do serial debridements as other described 2 to 3 days, once in 2 to 3 days, and cover with the skin graft or the flap cover after 1 week to 10 days.
Okay.
If arc burns are there, we'll wait because this progressive necrosis of tissues will prolong.
Okay.
So within 2 weeks we cover with the flap or the skin graft.
Even in
arc burns.
Okay. Ma'am, there is what author says is no patient died during acute phase, which is the most critical period where the mortality rate is very high in electrical burns. But 2 patients died during reconstruction phase with almost 30 days of hospitalization. What he attributed is the death should be maybe due to several attempts of surgical reconstruction of the affected limbs using local and distant flaps, where the surgical failure is attributed to the poor local vascularization, and in addition, because of high metabolic rate of the patient due to electrical trauma, which might be the predominant cause for those deaths. What is your opinion, ma'am, regarding this early reconstruction?
I had seen mortality in electrical burns in initial phase than in the late phase.
Yes,
in acute phase it is common.
It is common.
As I already described, various other factors. The cause may not be because of the multiple surgeries and all.
Yes, ma'am.
And when you do debridement and cover with vascular tissue like the local or the distant or regional flaps, it provides the vascular tissue for the part.
So
and it enhances the wound healing and protects the underlying tissue.
Yes, ma'am.
Enhances the functional status. I had seen the flap dehiscence insect giving away, but when we do the little debridement and give reinsert, it will take up and the wound will heal.
Yes, ma'am.
The many limbs were protected because of this EDAF method of
Early flap
cover after debridement.
Yes, ma'am.
So the death may be because of various factors in the electrical burns. It may not be because of the surgical actions. Yes.
Surgeries usually prevent those limbs and prevent the functional status and retain the function.
So the loss of vascularity in the limb may be seen, but not the mortality of the patient.
Yes, ma'am. Yes.
The flap will never die, but limb may sometimes go into ischemia. That is various reasons, because dependent position of the venous return may not be correct, and progressive necrosis may be there. Very rarely you see the gangrene of the limb, but not the patient going die, death of the patient.
Okay. Ma'am, you are repeatedly mentioning that you have a novel classification which you are regularly following at your institute. Can you please briefly tell about those classification, and also you are saying every time EDAF protocol. Can you please explain to our audience?
Yeah, definitely. For the last 7 years we are following this classification. We presented in Nabicon, and our PG got the best paper award for
Congrats,
that.
ma'am.
So we get different spectrum of electrical injuries of upper limb. So we see involvement of only fingers, and few present with compartmental syndrome, and few present with arc burns. So we always used to have some dilemma how to go about for treatment and assess. And everybody say there may be progression of the necrosis and all. So we observed over these 7 years these upper limb electrical burns, and formed a protocol institute classification for that. So Usmania PL classification we call it.
Okay.
So we categorized into 3 groups. The group 1 consists of only involvement of limited fingers, and they come with wounds or the gangrene of the limited area. So there is no compartmental syndrome, no arc burns in that, no gangrene. So we take the 3-4 factors into consideration in classifying this. One is extent of the wound, limited or extensive, and presence or absence of the compartmental syndrome signs, and presence or absence of the gangrene, and presence or absence of the arc burns. These are the 4 factors. If only small wounds to the tips of the fingers or the palm without any compartmental syndrome arc burns, it is a group 1.
Group 1.
So group 2 is a compartmental syndrome group.
Okay, ma'am.
So it is again classified into 2A and B.
Okay, ma'am.
2A will not have any arc burns along with the compartmental syndrome. 2B is compartmental syndrome and associated with the arc burns. And group 3, at the presentation the gangrene will be there.
Oh, gangrene at the presentation.
Gangrene without arc burns is 3A.
Okay, ma'am.
With arc burns is 3B. So we follow fixed protocol of treatment also for that, for this classified electrical burns. So the slides shows the spectrum and the classification. So group 1 we either treat conservatively or limited debridement we do, and group 2 EDAF. This group we can save maximum limbs by following EDAF. E means early. D means decompressive fasciotomy on day 1 and day 2.
Okay, ma'am.
And debridement or disarticulation once the patient is stable. That means that is also 1 to 2, day 1, day 2. It is a limb saving procedure.
Okay, ma'am.
And A means amputation, guillotine amputation, and F means flap cover.
Okay.
Flap cover, if the arc burns are not there, after serial debridements, as I told, with the intervals of 2 to 3 days, we do the serial debridement. If the bed is with the granulation, cover with the graft, or if the tendons are exposed, give flap cover.
Okay, ma'am.
If arc burns within 1 week.
Within 1 week.
1 week. And if arc burns are present, we'll wait for 2 weeks.
As you said.
And cover with the flap.
Okay.
Most of the times we follow the pedicle flaps, no free flaps
Okay.
in our institute. But few institutes they are giving the free flap also, but they are giving in third week.
Third week, okay.
Yes. So this is the protocol we are following, and we are getting very good results.
I have just one question. What is that Usmania PL? What is PL means?
Palakuri Lakshmi.
Okay. Usually in electrical burns, what we see is the most common emergency we encounter is arterial bloats. I mean, what is your emergency rate for your PGs? How well your PGs sleep? Do they get calls of bloats and everything?
During my PG period, I used to get called, and when I went and saw the patient was in pool of blood.
Yes, ma'am.
So immediately putting the tight tourniquet or the bandage and
Yeah, to
pressure
rush to
bandage and
blood
rush
bank,
to the
yeah,
patient to the theater.
Yes.
After following this EDAF method of treatment, I think hardly zero. We are not seeing any bloats now.
This is a nice thing, ma'am. Because that is the most terrifying emergency in
Yes.
ethical bank. Because we have to rush to blood bank, we have to rush to OT, and we have to do a lot of things.
Yeah.
If there is no blowouts, then your residents are the most happy residents.
Yes. Thank you.
We have a case of upper limb electrical burns group 2A, which after fasciotomy and SSG, we can see the full functional recovery of all joints of the hand. She is able to do her daily activities and lead a near normal life.
मेरा नाम मोहम्मद समी है। मेरा इंसिडेंट हुआ थिकल बर्न्स में मैडम डॉक्टर पी लक्ष्मी मैम ने सर्जरी किया था। बिलो एल्बो एम्पुटेशन हुआ राइट साइड, उसको आर्टिफिशियल लिम्ब लगा लिया। ये हैंड को भी टेंडन्स डैमेज हो गए थे, नर्व डैमेज हो गया था। इसकी सर्जरीज करके इसको थोड़ा बहुत इम्प्रूवमेंट ला सके, काफ़ी हद तक इम्प्रूवमेंट ला सके। डेली टास्क कर सक रहा हूँ अभी, पहले से तो बेटर कर सक रहा हूँ। थैंक यू फॉर डॉक्टर पी लक्ष्मी मैम एंड
गुड मॉर्निंग मैम। मेरा नाम जो है शेख अहमद है। मैं महाराष्ट्र से काम के लिए आया था। पट्टापल्ली फातिमा नगर में काम चालू था। मुझे जो है करंट शॉट लग गया। जो उस्मानिया में लाए तो बोले आप लेट कर दिए, बोले इन्फेक्शन हाथ में फैल गया, बोले आपका हाथ जो है निकाल देना पड़ता उल्टे बोले। तो लक्ष्मी मैडम जो है हाथ बचा दिए। पैर भी जो है पूरा आपको डैमेज था, पैर से भी मेरे को अब चलना आ रहा, हाथ से भी काम कर सकूँ, खाना पीना खा ली सकूँ। पहले कुछ भी नहीं आता था, बिस्तर पे था 6 महीने तक, तो बिस्तर पे था। जो मेरे जो 5-6 जो सर्जरी जो कराए उसके वजह से मैं ज़रा ठीक हो पाया हूँ। पहले से मेरी कुछ बचत हो गई, तो लक्ष्मी मैडम जो है बहुत अच्छा की।
And to conclude the article, what author's conclusion is, to decrease the morbidity and mortality in electrical injuries, the treatment of acute phase of electrical burns must include, what he says is 3 points, ma'am. One is immediate and adequate replacement IV fluids and controlled urine output so that the CPK level should be very less. And third point is, with surgical procedures of debridement and amputation as early as possible in stages with interval of 48 to 72 hours will reduce the mortality and morbidity. What is your final opinion, ma'am, regarding this?
I do 100% agree with the author, and we are also following the same thing.
Like early debridement and amputation as early as
possible.
as early as
And
possible.
flap cover also.
And flap cover also. Okay. Thank you so much, ma'am, for coming today and sharing your valuable opinions and your experiences regarding electrical burn injuries. And you have enlightened us with a lot of protocols and classifications which we have never heard of. And thank you so much, ma'am. Thank you.
Thank you, Rohit.